So now we are going to the knee, and in the knee you have 3 positions available to detect fluid or blood. The first position is the suprapatellar recess or bursa in long axis and perhaps also in short axis, but you see that I'm anchoring the knee and following the bursa to the top. Peter, maybe you will freeze the image. And this is what we are seeing. Peter will explain.
So here we're looking at the suprapatellar area of the knee. Here you can see going from left to right. So left side of the image is proximal, right side of the image is distal, down towards the feet. We have the femoral cortex here, bone, again, trying to keep this femur, and any time you're ultrasounding, keeping the bone as crisp and sharp and clean as possible. Superficial to that, we have a fat pad that's here. That's the prefemoral fat pad. Then we see this dark line, kind of looks like a T, the letter T right here. That is my suprapatellar bursa. And bursa, it's not actually a bursa, it's actually just an extension of the tibiofemoral joint capsule. On top of the bursa, we see the quadriceps tendon attaching onto the patella, which is right over here, this bony cortex here. And then superficially to that, we have fat and skin. Going back down to the suprapatellar bursa down here, this is where blood would then occupy. So in my knee, there's a little bit more fluid than normal, but not excessive. But then this area here would then occupy this entire space, all right here. As you can see, the joint fluid would then come from this space here, exits proximally to this area, the suprapatellar bursa, and occupy this. Again, it would be dark, hypoechoic, and speckly appearance, and then with sonopalpation, it would be compressible, fully compressible.
Peter, I want to point out the patellar tendon going into the patella.
Yep, so this is the quadriceps tendon attaching onto the patella here. We have some loss of fibrous echotexture here, which means that a little bit of tendinopathy, a little bit of tendinosis here right at the attachment onto the patella, which is not surprising for me. I'm pretty active. I exercised this morning, so but it's not giving me any pathological symptoms right now. So maybe if I continue to do my PT, my self PT, that'll continue to get better. But you can see there's a little bit of a loss of fibrous echotexture here at the attachment.
So good. So the second position to detect fluid is here in the medial recess. The top of the probe is anchored at the patella and the bottom of the probe at the femur. You can see that I'm toggling my probe sideways, that I'm heel toeing in terms of finding the right position. Heel toe maneuvers, toggling maneuvers, but I think we are in a good position here. Now you see the hypoechoic area. Peter, maybe you can point towards it.
This area.
This area here coming out of the joint space, and maybe Peter, you relax or you unfreeze the picture again. I am compressing now. See, I'm applying compression to the joint space, and this area is not compressible, meaning it's probably a little bit of synovial, or let's say soft tissue hypertrophy coming out of this space. We will freeze now. Again, Peter is very active. It's an incidentaloma, but we can measure this out. And we do that with the JADE protocol quite frequently. And it shows as about, oh no, I would just do yeah, exactly 0.3 centimeters or 3 millimeters. And that is upper line, let's say upper range of normal. In the joint space in the knee, synovium should not necessarily exceed 2 to 3 millimeters. So here we have 0.37 centimeters or 3.7 millimeters, so a little more than one would expect. But again, Peter is a very active guy and maybe a little sports injury or such. Good. We now come to the third and last place to detect bleeding. Or Peter, would you like to we should maybe explain that picture a bit.
Okay. So here we have the medial recess of the patellofemoral joint. Here on the left side, we have the patella. So this is lateral. Left side of the image is lateral, right side of the image is medial. We have the patella here, and then we see again the femoral cortex here. It should again try to keep it bright and white and hyperechoic and crisp and clean. In this, between these two bones is going to be your joint space, so blood will be exiting out of this area into and occupying this area, actually where we see that synovial or soft tissue proliferation here in my knee. We then see this bridge-like tissue that's coming off of the patella, coming down and kind of dipping down towards the femoral cortex and coming off the edge of the screen there. That is my medial patellofemoral ligament. So everything deep to this ligament is going to be considered still within the joint capsule. So we can actually see a little bit of a line here that distinguishes where the joint capsule ends. So then everything deep to this is going to be within the joint capsule. So a bloody effusion would then occupy this space and push this tissue that's here, this hyperechoic tissue, superficially, and even sometimes this tissue, this ligament that is kind of bowing down towards the cortex would actually be kind of ballooned up towards the skin in this fashion.
And the third and last position here for bleed detection is in analogy to the medial recess, producing the lateral recess. And again, I am heel toeing the probe, I am toggling the probe just to get a very crisp image. And Peter will freeze that for you. And just in analogy, Peter pointing out the patella, pointing out the femur, and pointing out some soft tissue originating from the joint space, a very small stripe here of synovium, clearly under 1 millimeter or 2 millimeters for sure.
So now we're going to take a picture and view Dr. Wondrowski's knee. She has some arthritis going on in her right knee. And so we're going to take a look at it, and I think there's going to be a little bit of an effusion here. So this will kind of replicate what a hemarthrosis may look like, or how it would kind of present inside of the suprapatellar bursa. So again, you're going to have the reference end proximal, non-reference end distal anchored on the patella. So you're going to be in this position here. I'm going to adjust my settings here. I'm going to drop my depth down a little bit. And you can see here, again, we'll pause it here just for a moment. We can see the femoral cortex here. We can see the fat pad. And then we see that suprapatellar bursa, where in my knee, it kind of looked like a little T. And then with Dr. Wondrowski's knee, you can see it occupies this space. So this fluid inside of here looks very anechoic. It's not as grayscale as you would see with a hemarthrosis. You would see more speckles. It's a little grainy. That's because of the machine itself, but for the most part, you would see really bright speckles with a hemarthrosis occupying this space. Going back to the live image, we can then do some sonopalpation to start, which is by pressing my probe down and letting off some of the pressure, and you can see how this substance acts a lot like fluid. It is fully compressible. If I were to push harder, I could probably make all of that go away. And then we can also do some dynamic movements as well. And I'm gonna ask Dr. V to slowly flex and extend. As you can see, as she extends, that space is then occupying even more. You can see some little floaters in here that are some soft tissue, loose bodies that are kind of floating around in there. Go ahead and flex your knee again. So this is another way to, again, verify if we have fluid inside of the joint. If this was purely tissue, you wouldn't see that swirling of speckles or loose bodies. You would just see this kind of mishmash and squeezing compression of tissue. But as we can see here, we have some fluid with some loose bodies that are kind of floating around in that. So this is kind of what a hemarthrosis would look like. or in the sense of where the position and location that it would be in. But this specific fluid that's within Dr. V's knee is not a hemarthrosis. It is anechoic. It is pure black fluid, but then has these little loose bodies within it. Now we're going to take a look at Dr. Von Grauski's medial recess of her knee, the same knee that had that effusion on the suprapatellar bursa. So again, we're going to have the reference end on the patella, non-reference end on the side where the femur is located. And right now I'm just kind of toggling my probe, going proximally, distally, just checking the entire geography of this medial side of the patella. And as we can see here, I'm going to pause it here. We can see her patella over here on the left-hand side. We see her femur over here on the right-hand side, nice and crisp and clean. We can actually see down into the joint space, into the patellofemoral joint space. And coming out of the joint space, we see this hypoechoic area that is kind of creeping out medially down her femur, and we can see all of this substance that's here. So now my job is to find out what kind of substance it is, if it's hypoechoic, if it's anechoic, if it's tissue, if it's fluid. So we'll go back to a live video, and I'm going to try some compressibility and just pressing my probe, letting off almost to the point where my probe is coming off of the skin and pressing down more. We can see it's kind of a mixed of things. We see some fluid down in here, down closer to the joint space, but then we see some more hyperechoic, not anechoic substance that's here that's not really compressible. It's really non-compressible. So I would call that, and you can see it moving around within. So I would call this some tissue, soft tissue proliferation that's sitting kind of more closer on top of the femur, along with some anechoic fluid that is kind of dispersed within and around that tissue.
And I think one important point to make, you can see that my knee is not swollen, and you will see that in some of your hemophilia patients. An effusion does not always have to be balloon-like with a swollen joint. It can sometimes be just a normal joint, but with some fluid in there, some blood in there, something we call silent or asymptomatic bleeding. We are not quite sure what that means in terms of joint destruction, in terms of treatment recommendations, but just to make the point, this would be just silent or asymptomatic, an asymptomatic effusion. I have no symptoms, I have no pain.